is Zahirah. So today our group will present about the case 2 regarding nutritional management for patient diagnosed with diabetes, mellitus and CKD, chronic kidney disease. So let's start with patient personal details. So this is Puan AL. She is 61 years old, Malay and already married. Puan AL is admitted due to profuse sweating. So from patient report, it is shown that Puan AL has no family history of diabetes, mellitus and CKD, but her medical history show that she has hypertension, diabetes mellitus since 2005, CKD stage 4, CKD secondary to diabetic nephropathy with persistent hyperkalemia and hyperlipidemia. She also ADL independent when she able to ambulate in the ward. Lastly, she has less knowledge on food choices and ready to change her lifestyle. Next, we move to the medical diagnosis. Puan AL is diagnosed with uncontrolled hypertension, resolved symptoms of hypoglycemia secondary to oral hypoglycemic agent, acute on chronic kidney disease precipitated by angiotensin converting enzyme inhibitor and hyperlipidemia. So let's see the relation of diabetes mellitus and hypertension with CKD and hyperlipid. For diabetes mellitus, it occurs due to impaired function of insulin, which causing blood sugar to be elevated. Hence, it can damage the nerve and blood vessel, leading to other disease, which are hypertension, hyperlipid, and CKD. So, patients with diabetes mellitus usually increase in number of VRDL, and large VRDL will produce. As a result, prolonged diabetes mellitus will cause patient experience hyperlipid. When patient has hypertension and diabetes mellitus, it can damage the renal blood vessels, and as an effect, it will impair kidney function to filter blood and waste product. So patient with hypertension usually consume angiotensin converting enzyme inhibitor, but this will cause early decrease in glomerular filtration rate, thus lead to acute CKD. So when CKD occurs, it cause accumulation of fluid and waste in the body, which will also elevate the blood pressure and cause hypertension to occur. At the same time, patient with CKD will also experience hyperlipid as a result from downregulation of lipoprotein lipase and LDL receptor delay the catabolism of TG-rich lipoprotein. To conclude, diabetes mellitus, hypertension, CKD and hyperlipid are interrelated with each other.
Hi, my name is Fatihah. Alright, so these are the medications taken by Puan AL. The drug used to treat hypertension is T-prazosin, which is an alpha blocker, T-metoprolol, a beta blocker, and T-dialtazone, which is a calcium channel blocker. The side effects include palpitations, nausea, dizziness, and headache. Next is T-marzolone, which is used to treat nausea and vomiting. The side effects from these drugs are drowsiness and restlessness. T-ranitidine and T-pantoprazole are two anti-reflux agents used to treat gastroesophageal reflux disease, or known as GERD. Consumption of this drug usually cause headache, drowsiness, nausea, and vomiting. The drug disease and food-drug interaction are as stated below. The next drug consumed by Puan AL is calcium carbonate, which is an antacid. It is used to treat hyperphosphatemia in chronic kidney disease patients. The side effects include nausea and loss of appetite. Next is double hematinic, which is used to treat and prevent low blood levels of iron, usually caused by anemia. Diarrhea and constipation are the most common side effects of this drug. T-simvastatin, which is a statin drug used to lower the blood cholesterol level. The side effects may include nausea and headache. Next is oral kalimate, which is used to treat hyperkalemia in renal failure patients by lowering the blood level of potassium through excretion. Nausea and vomiting are the most common side effects from the usage of this drug. Insulatard and T-gliclazide are two drugs used to treat type 2 diabetes mellitus. High dosage of these two drugs may cause hypoglycemia. The drug disease and drug-food interactions are as stated below.
Assalamualaikum and hi guys, my name is Shamimi. So I will continue this presentation with the first part of nutrition care process for Puan AL, which is assessment. So let's start with the anthropometry part first. Based on her height and weight, we can categorize her BMI as normal, and then we calculate her ideal body weight and ideal weight range. And then we also calculate her dry weight because she is a renal patient. So we will use this dry weight to intervene her diet after this. And her dry weight is 52.2 kg. Okay, then for her biochemical profile, we can see here her urea and creatinine levels are very high, and her chloride level is quite high. And this may indicate her renal problem. And then her sodium level is quite low. This may be because of she has condition of profuse sweating. And then her hemoglobin and red blood cell are low, maybe because of she has loss of appetite since 2 months ago. So she may not get enough protein and iron to build her red blood cell. And then for clinical part, we can see that her blood pressure are very high. Her blood pressure can be categorized as hypertension stage 3. And for others parameters, which are pulse rate, body temperature, and oxygen saturation are normal. And for her dietary data, based on her 24-hour diet recall, she has very low energy intake, which is only 510 kilocal, and 94.1% from that is contributed from carbohydrate. So let's see after this what is our intervention for this patient.
Assalamualaikum and hi, my name is Qudhiati. I will proceed for nutritional diagnosis. As my friend mentioned before, in the nutritional assessment, we found that Puan AL's energy intake was very low, which is 510 kilocalorie, and she also reported that she had low appetite. Therefore, our first nutritional diagnosis is inadequate energy intake related to low appetite, as evidenced by 24-hour diet recall, which is 510 kilocalorie. Besides that, we found also her biochemical parameter for urea and creatinine were very high compared to normal range. So, we come out with the second nutritional diagnosis, which is altered nutrition related laboratory value related to acute on CKD, as evidenced by high urea value 24.6 mmol per liter and creatinine value 600 mmol per liter. After nutritional diagnosis has been identified, we move to intervene her nutritional problem. To find out Puan AL's energy requirement, we use Quick method and HBE. Energy from Quick method was multiplied with stress factor 1.4 because she had renal failure, and activity factor 1.0 sedentary. So, the energy range will be 1146.2 to 1600 kilocalorie per day, and we finalize her energy requirement 1600 kilocalorie. We also aware that she had CKD, therefore we manage her protein intake by giving low protein diet, which is around 31.3 gram to 41.8 gram. From 1600 kilocalorie, we distribute 59.5% of this total energy intake for carbo, 10.5% for protein, and 30% for fat. Then, we calculate for food exchange by distribute this macronutrient in food distribution table. So, we get 11 exchange for carbo, 2 exchange for protein, and 8 exchange for fat. This is food distribution table that I mentioned before. After we get exchange portion for each food groups, then we distribute it according to 6 meal times. 6 meal times because she had low appetite, so we plan to provide small and frequent meals. For sugar, we give 1 exchange for breakfast and 1 exchange for afternoon tea because she usually drink tea at this time. So we take into account also her usual eating pattern. Our short-term goal for this patient is to ensure Puan AL gets as adequate energy and nutrients as possible to prevent the patient from being malnourished in the future. Next, short-term goal is to improve the urea and creatinine value within 1 month to delay the progression of CKD. Hence, we provide her with low protein diet to reduce the workload of the kidney.
Hi, my name is Siti Nurezzatul, and now I will explain on objectives and principle, menu planning, as well as monitoring and evaluation. So we have 2 objectives for this patient. The first one is to ensure that she gets adequate energy and nutrient as much as possible, and the second one is to improve her urea and creatinine value within 1 month. So for the first objectives, the principles are: we will provide her with adequate energy of around 1600 kilocalorie per day, low protein and low fat diet, considering her kidney status and hyperlipidemia. We will also provide her with around 1.5 until 2 liters of fluid per day, considering her profuse sweating, so that she will not be dehydrated. And for the second objective, the principle is we will give her low protein diet of 0.6 until 0.8 gram per kilogram of body weight per day with high biological value protein. So moving on to the menu planning, we suggested her with 3 menus. for which 2 for weekdays and 1 for weekend. From all the menu, she will get around 1,600 kilocalorie of energy per day, low potassium, low phosphorus and low sodium to improve her blood pressure and kidney status. We also provide her with small and frequent meals of nutrient and calorie-dense foods so that even when eating at small portion, she will get enough energy and nutrient. So for monitoring and evaluation, we will assess her BMI so that she maintain her weight and not experience severe weight loss. We will also assess her biochemical data such as urea and creatinine value, blood pressure as well as dietary intake so that our objectives are achieved.
Hi everyone, Assalamualaikum. I am Alifah Solihah. So today I will continue with the discussion part. First and foremost, Puan AL is diagnosed with uncontrolled hypertension stage 3, resolved symptom of hypoglycemia secondary to oral hypoglycemic agent, acute on chronic kidney disease precipitated by angiotensin converting enzyme inhibitor and hyperlipidemia. She is admitted due to profuse sweating, which may indicate that she experienced hypoglycemia due to low energy intake and low appetite. However, the condition of hypoglycemia has already been resolved by oral hypoglycemic agent. Before this, my friend had explained how all these diseases interrelated with each others. According to her medical history, she had experienced hypertension and diabetes mellitus, which become the risk factors of chronic kidney disease and subsequently develop hyperlipidemia. Next, let's move on to the dietary management. Since Puan AL has poor appetite, we plan a menu suggestion that focus on the small and frequent meals with energy-dense food and drinks such as curry puff, sweet fruit cake, and also chocolate milk. The daily requirement calculator is 1,600 kilocalorie with macronutrients distribution of 59.5 carbohydrate, 10.5 protein and 30% fat considering her hyperlipidemia. This is to ensure that she obtain enough daily energy requirement to maintain her current body weight and also to prevent malnourished. Considering her current states of creatinine and urea profile, low protein diet which is 0.6 until 0.8 gram per kilogram per day with high biological value is recommended in order to lower the nitrogen waste product which will eventually reduce kidney workload by reducing intraglomerular pressure and hence lowering the progressions of kidney disease. Moreover, consumptions of low protein diet can also reduce the creatinine and urea level in the blood, thus reduce the susceptibility of renal insufficiency. Next, high dietary intake of potassium and phosphorus among chronic kidney disease patients will lead to hyperphosphatemia and hyperkalemia. Since potassium level is regulated by the kidney, poor functioning of kidney will cause potassium build-up and cause heart problem. Hence, potassium intake is limited to less than 2,000 mg per day. Meanwhile, high sodium intake will lead to high blood pressure. Thus, sodium intake is restricted to less than 1,500 mg daily, considering the patient has stage 3 of hypertension. Phosphorus, sodium and potassium are usually present in meat, poultry and fish processed product as additive. For the fluid intake, the recommendation for Puan AL is between 1,500 to 2,000 ml per day to maintain her hydration status considering her condition of profuse sweating. Overall, it can be concluded that Puan AL experienced diabetic nephropathy due to prolonged diabetes mellitus and hypertension. Hence, the dietary intervention emphasized on low protein diet (LPD) that helps in improving her renal profile that include creatinine, urea, sodium and potassium level and thus slowing the progressions of kidney disease. In addition to her low appetite condition, small and frequent meals with energy-dense food are provided to fulfill her daily energy requirement. Puan AL also needs to regularly check her renal profile monthly to avoid any complications from chronic kidney disease condition such as toxic accumulation in the blood. Lastly, Puan AL should comply with the recommended dietary management in order to have a better quality of life. That's all from us. Thank you for watching. Hope you enjoyed this video. Thank you.